Nice to be back. Thank you for inviting me, Dr. Singh, back to Cleveland. I've been 6 different places. Cleveland Clinic's the best place I ever worked. The best doctors, but also the best patients. When you do clinical research like I do, you have to have a very knowledgeable and a very compliant patient population. And I haven't found more knowledgeable or compliant patients anywhere else in the country that I've been. So I'd like to thank all the patients out there that took part in the trials that I did. I made this slide for you, Dr. Hovland. Adjuvant comes from the Latin, adjuvare, to aid, an agent that modifies the effect of other agents. So adjuvant therapy is additional cancer treatment given after the primary treatment to lower the risk that cancer will come back. So what I'm just going to do in the next 5-10 minutes is just kind of build upon the things you've already heard this morning and talk about adjuvant therapy, give you maybe a little different perspective. Okay, so here's the model we work with for adjuvant therapy. We think in some patients at the time of primary diagnosis, when the tumor manifests in the eye, some of those patients will have microscopic amounts of tumor. So we can't see it, but we know that because they're going to metastasize, that they have macroscopic tumor at that time. And as time goes on, these microscopic bits of tumor become bigger, become macroscopic, and we have metastasis. The other thing in this model is this, that when you have microscopic tumor, your immune system is working really well. When you have big tumors, when you can see it, the immune system goes down. The other thing, as time goes on, the tumor figures out a way to become more resistant, to be more aggressive. So time goes. So their ability to treat probably is best right here. Treat the primary tumor, but also treat systemically the microscopic. And then you'll improve survival. So that's the model, and that's the approach we take, and the rationale for treating someone with something systemically, something goes everywhere in the body at the time or after their primary tumor is taken care of. In skin melanomas and cutaneous melanomas, we do that, and we have a drug called Interferon that was indicated for that problem. Patients with high-risk skin, we cut the tumor out. We know they have features that are going to tell us that's going to come back or metastasize. We give interferon for that. And I just want to show you, just to give you some context on how well this works. And this is looking at relapse-free survival that we heard about. On this graph on the left, okay, so relapse-free survival. So as time goes by, years, so every time someone relapses, the curve goes down. So on the top are the people that got interferon, and on the pot are people who were just observed. So as you can see with time, there is separation. When you're on top, you're doing better than on the bottom. This is the relapse-free survival. This is the time from diagnosis till it comes back or metastasized. This is overall survival, how long people actually live. And when you look at interferon, there is some separation versus observation, but it's not that great. So this is as good as we do right now with skin melanoma. So this is kind of our background and how we approach it. And it's hard to give really good numbers, but I usually tell patients of mine with skin melanomas that we can delay metastasis by 50%, maybe a little more. We can improve your survival by 10%, maybe a little less. People have been on interferon, look like that. You feel like you have the flu. So interferon is a substance your body makes when you have a viral infection, and not surprisingly, you feel like when you start out with it. I think with the flu-like symptoms, the more you get, actually your body adjusts to it. Long term, you get loss of appetite, depression, fatigue. It's not a benign drug. And so we have to measure that in base of those 2 curves I showed you. There have been some trials, adjuvant therapy trials in uveal melanoma. They use a substance called BCG. It's actually an immune modulator, and a chemotherapy drug actually was given in high doses. And these were randomized studies, 100 and 300 or so patients. They didn't show they had any effect on these. These were randomized trials, so half the people got the treatment, half the people were just observed. Problem with that is that BCG and dacarbazine at this doses really doesn't do anything even in skin melanoma. So it's kind of hard to say, you did really test these drugs in the proper way in these studies. We have looked at interferon in uveal melanoma. These are non-randomized studies. These are studies where everyone got treatment, and you see the numbers 39 and 55, and these were compared to historic controls and didn't show any benefit. So what we just heard a few minutes ago from Dr. Amato, you need, what, several hundred patients? These aren't real powerful studies. The other thing, too, in skin melanomas, we don't give interferon like this. We give much higher doses of that. So again, probably not a real good test. Interestingly, so where does melanoma of the eye metastasize? Goes to the liver. In Europe, they tried putting chemotherapy in the liver right off the bat. And again, a small number of patients. It really didn't show like it had an effect on that. So when we look at adjuvant therapy, so when your doctor kind of hems and haws about whether or not to offer you adjuvant therapy, the problem is he does not have good data to base any decision on. And when we assess the ability of an adjuvant clinical trial to give you information, we look at whether they got something that actually worked. We want to know about the risk group, how many people were actually treated that are actually going to metastasize. When you randomized, did you have a good control group? And was a study big enough to give you information? No, no, and no, and no. So that's where we're at as of October 25th, 2014. Key question everyone has is, who is the best patient to put on this? All right, so how many people, when you do a trial, can you tell those people are actually going to recur within that first 5 years to make a study worthwhile? That's the key question. And we've heard from Dr. Singh, Dr. D'Amato, and others this morning about how we do that. But one of the things, all these treatments I talked about for uveal melanoma came from studies we did in skin melanomas, and there's big differences. Like Dr. Singh mentioned, we don't know what the sun plays in uveal. The mutations are different, and then this is the big difference. Uveal or ocular melanoma gets in the blood, goes to the liver. Skin melanoma has a predilection of getting the lymph in the lymph node. So two different diseases. In skin melanomas, we know when you're going to recur because we can see it with our eyes. If it starts here in your leg and goes to your lymph node, we know it's spread. We have objective evidence that it's spread. We don't have a similar test for uveal melanoma right now. We base it on those clinical things you heard about. These are information that we can get from a biopsy or just by looking at you. And then this revolutionary development of these molecular prognostication where we can get a better idea. And I think as you saw in Dr. Cebola's presentation, and also I think Dr. D'Amato referred to, we're kind of getting a better system where we use some of those clinical, some of those biopsy, and some of this information to come up with a better idea who is going to relapse, who is going to metastasize. Dr. Cebola showed you the list. There's a lot of things going on. I have to update this. I only have the MEK inhibitor is different than the MET inhibitor. I'll add the MET inhibitor as soon as I get back to North Carolina. What can we say? This is the rationale. Adjuvant therapy. Treat at the primary before macro or tumors you can see manifest. At present, there's really no evidence any of these things do anything. And the reason why, we just haven't studied this well enough. And we haven't applied the best treatments. We're now, and the number of patients at risk in these studies are not known. We're now more rationally applying treatments using the genetic criteria to identify patients at risk. And and you saw the list, a lot of immune-targeted therapies. This MET inhibitor looks like it's going to be a real good compound. These are being investigated, and these are being investigated in people that have the liver metastases, but also now if they work there, the thought is let's move them up front, and we're making progress in that. And one of the other things, and some things I've been working on, is not try to get rid of that microscopic amount of tumor, but give a drug that keeps it small. So if it doesn't grow, doesn't cause liver problems or metastases, it's as if it's not there. So a lot of people are thinking different approaches instead of trying to just get rid of and kill the tumor, doing approaches that will keep things under control. More Latin for Dr. Hovland. Magni progressus sunt effecti. Great progress has been made. We're very optimistic about the future. Thank you.